Next speaker will be Dr. Wafa Alqabandi, and Dr. Wafa Alqabandi, pediatric gastroenterologist from University Kuwait, and her topic will be a liver transplant in metabolic disease. Welcome, Dr. Wafa.
Assalamu alaikum. For the organizers, I'm too short. For the organizers, thank you for the invitation, and thank you for organizing such a wonderful meeting. My presentation is about liver transplantation, metabolic liver disease. Okay. I have nothing to declare. Doesn't it? Excuse me? Yeah. This is the outline of my presentation. It's indications of presentations of metabolic liver disease, indications, international data, living-related donors, listing of these patients on the disease list, transplant, monitoring post-transplant, and disease recurrence, and then a bit about our experience in Kuwait. Now, metabolic liver disease, there are diseases caused by a defect in a single enzyme or transport protein that alters a metabolic pathway. The liver is a highly metabolic organ, so lots of these metabolic pathways occur in the liver, whether it's synthesis or destruction of carbohydrates, lipids, proteins. Many of these pathways occur in the liver. And any dysfunction of these, these steps may lead to hepatic or extrahepatic manifestations. Now, presentations, how do metabolic liver disease present? They present either with liver disease or extrahepatic disease. So, and sometimes they have both liver and extrahepatic manifestations at the same time. How do hepatic disease present? They either present with acute liver failure, either in the neonate or in an older child, but with recurrent fulminant liver failures, and in between the child is normal. And examples, tyrosinemia, galactosemia, and these are just examples. There are multiple diseases. Or they present with cholestasis and chronic liver disease, like PFIC patients, alpha-1 antitrypsin, cystic fibrosis, and others. Or they can present with hepatomegaly. Excuse me. Okay. Extrahepatic disease, the metabolic defect or the problem is in the liver, but does not produce a liver disease. It produces disease in other organs, although the defect is inside the liver. So there is no liver disease, but there is extrahepatic manifestations, and mainly regarding CNS, the brain is affected, or kidneys, or the cardiac. Examples like Crigler-Najjar, hyperoxaluria, urea cycle disorders, and MSUD. These extrahepatic manifestations can be very serious and can lead to death in some of these patients. So these are serious diseases, although we don't have liver disease. Now, epidemiology, altogether, the metabolic liver disease, they are considered rare, but in some parts of the world, they are not rare. They are, we cannot say common, but they are, more than rare. According to the WHO, they are estimated as 10 in every 1,000 births, and they can cause significant morbidity and mortality. How do we manage metabolic liver disease? Either medical management or liver transplantation. Regarding medical management, mainly, it depends, of course, on the specific metabolic pathway which is disrupted. So most of these patients will need dietary restrictions and supplementation of essential products downstream the metabolic block. When the product is not produced, we have to give this supplement. Or sometimes we also have to give medications to dispose toxic metabolites, and medications that also enhance the enzymatic activity of the mutant protein, or some replacement of some enzymatic cofactors. So it's a hell of a work. And metabolic specialists, they are not, it's very difficult to deal with these patients. So medical management is extremely challenging for the patients and families. And the barriers to successful medical management, because the highly restricted diet is really very difficult to achieve and to follow. And they are also liable to get metabolic decompensation. Even if you have highly restricted diets, they always, during intercurrent illnesses, they are liable to decompensation, and even they can be admitted to the ICU. So it's a serious, these are serious diseases. And many of the also hospitals or centers, they lack the availability of specialists, the metabolic specialists. They can deal with these kind of diseases. So here comes the liver transplantation for metabolic liver disease. Liver transplant can provide curative treatment or can improve the quality of life. So it can cure the disease or can improve the quality of life but does not cure the disease. So how does liver transplant is curative? The new graft has sufficient enzyme that deals with the metabolic defect, okay? So it will eliminate the need for dietary therapy after liver transplantation. Example, MSUD, maple syrup urine disease, and Crigler-Najjar syndrome. And the liver transplant in certain conditions does not cure, but may improve the quality of life. And these patients have significant extrahepatic expression of the defect. So it's not only the liver has the defect, also in other systems. That's why even if we could give them a new liver, it will not improve the condition because the enzyme defect also available or expressed in a high way in other systems. The donor liver will efficiently, so what do we do liver transplant? The liver can deal with the residual abnormal metabolites, so it improves the condition, although it does not cure it. Example, organic acidemia. Now, liver transplantation is, in these patients, considered to be a gene therapy. We are giving a good gene to this gene defect in these patients. So some international data on transplanting these patients. In USA, there was, in the split registry, there was like 446 patients of metabolic liver disease transplanted among 3,000 liver transplants, pediatric, and 446 were transplanted because of metabolic liver disease. So around 14.9%. This is in the States. In Europe, also a multi-center study, 17.3% of the transplant indications in pediatrics was due to metabolic liver disease. In Japan, 8.7% of the indications in pediatrics for liver transplantation is for metabolic liver disease. In the split registry in USA, look at they compared the patient survival and graft survival between those transplanted for metabolic liver disease and those transplanted for non-metabolic liver disease. Even the ones transplanted for metabolic liver disease, they have better patient survival and better graft survival. And this is statistically significant. In Japan, they reported even up to 15 years, the patient survival and the graft survival. So these patients, they do well after liver transplantation. The metabolic liver transplanted children, also they were reported to have less complications with surgery post-transplant, less GI complications, less portal vein thrombosis, and less the need for reoperation within the first month post-transplant, which means that the metabolic liver disease experience, they experience better post-transplant results. And now, currently, metabolic liver disease is becoming the second common indication for liver transplant in children after biliary atresia. This is the Japanese study showing how it is getting more and more, metabolic liver disease are getting more and more transplanted over the years. So previously, in 1990 to 1995, this is always the hepatic diseases, but now as we approach the 2010, it's, more metabolic liver disease are getting transplanted. Now this table shows the different diseases that require or they go for liver transplantation as treatment. And the types of transplanted diseases differ according to the region. So in the American data on the left side, mostly urea cycle and alpha-1 antitrypsin. In the Japanese data, it's mostly Wilson's disease, and then comes urea cycle. And the Korean data also goes with the Japanese data, the same. So why I'm mentioning all these? Because these are, large studies, and they included like around 3,000 patients, pediatric patients. Now, what about donors for these patients? They can have either deceased donor or living-related donors. The majority of these patients or these diseases are autosomal recessive. Okay, so this means that parents are obligate carriers. And where do we get the donors? We get them from the parents. So it means that the parents, they have the disease. They have not the disease, they are carriers for the defect. So are the heterozygous donors safe? According to the Japanese study, because Japan and Korea, they have the largest group of living-related donor transplants in the world. Okay, 95% of the donors were parents. So even the heterozygous donors, they are heterozygous donors, but they are safe. And the outcome of so they concluded in their study that the outcome with heterozygous donors was excellent with better long-term survival. They reported the survival up to 15 years. What about this is also in Korea. More than like 3,000 patients transplanted, 54 were metabolic liver disease, and they also found that the heterozygous donors were safe. Now, so liver transplant from a heterozygous donor is safe and effective approach for metabolic liver disease. So why do we need heterozygous or living-related? Because we need, liver transplant, so donors are safe. Excuse me. So the heterozygous donors are safe for metabolic liver disease, except in urea cycle ornithine transcarbamylase deficiency. Why? Because it's an X-linked condition, so the mothers should be excluded. What about the fathers? Fathers, there was a report of a donation from a father to another patient, and the patient developed the disease. So do we have to measure the enzyme in the fathers? We don't know. This is debatable. Do we have to determine the enzyme activity in these heterozygous donors of urea cycle? It is debatable. Now, why do we need a living-related donor? Because we need to transplant these patients early enough before they get the CNS problems, and the extra-intestinal manifestations are worse, so they have developmental delay. So we need to transplant them before they get these problems. That's why we need living-related. We don't want them to be put on the transplant list and wait forever. So listing for disease donor transplant, conditions which have liver damage, which have liver disease, they can follow the MELD and PELD scoring. The same, we can consider them as other diseases having, liver cirrhosis. But conditions with no liver disease, there is no meaningful MELD and PELD score on the transplant list. So there was a group found in the MELD group, MELD Exceptional Case Study Group, message. They founded this group in 2006 to look at these cases and individualize the case according to the extrahepatic seriousness of the extrahepatic disease. So they take care of each disease by disease to know exactly where to put them on the list. Urea cycle disorders, they have special onus policies for the listing. And other conditions, patients are discussed with the local onus regional review board to decide what to do with these patients. Otherwise, they will put on the lower part of the list, and they will not get diseased liver transplantation because they don't have a liver disease. Perioperative monitoring, remember that these patients are susceptible to metabolic decompensation during stressful events, which is anesthesia and surgery. That's why they have to have a well-prepared perioperative monitoring and management. Many synthetic the anesthetic drugs are safe, but there are certain conditions that you can't use, like propofol for organic acidemia. So you have to have also, some guidelines in managing these patients preoperative and perioperative. So we need a multidisciplinary team with experience in managing these patients. Now, a bit about mitochondrial cytopathy. do we transplant these patients? Remember that these patients, when they have hepatic, they have extra hepatic manifestations, they can have it later. So they can be transplanted, and then later they will develop the CNS problems. So these cases are debatable. And there was a report from Lee and Sokol reported the survival rate of these patients of mitochondrial hepatopathy who was transplanted. They had the survival rate was 30% in these patients. So it's not that good. So always individualize these cases. How do we follow these patients post-transplant? We have to monitor the conditions that are cured by liver transplant. We don't have to have dietary management, and we can follow them as another patient who had liver transplantation. But conditions that incompletely treated by liver transplant, they need metabolic management, so the metabolic specialist has to follow these patients. They have to have some kind of dietary restrictions, and they have to have some kinds of supplements too. So we don't say that the transplant was done and that's it. No, these patients are liable to get extra hepatic manifestations. And we have also to continue having occupational, physical therapy because they might have pre-transplant problems. This table shows what to do in each disease. The disease is cured by liver transplant and how to follow. Remember always that the patients who were cured by liver transplantation, they might have pre-transplant CNS problem. So the transplant will not prevent the new development of CNS problems, but it does not improve the pre-existing CNS problem. So the new development of CNS disease, this will be prevented, but not the previous one. That's why we have to follow these. And diseases with continuous metabolic derangement post-transplant that were not cured by liver transplantation, we also have to look into the other systems that the disease involved them. Now, remember that damage to the brain, kidney, and heart is progressive, and unlikely that liver transplantation can improve it. So we have to plan liver transplantation in these patients early enough. That's why we need living-related better than waiting on the transplant list. Now, disease recurrence after liver transplantation. I concentrated on metabolic liver disease, the inborn errors of metabolism, more than PFIC, because Dr. Iman has presented PFIC. But just a bit about recurrence disease in PFIC2. Patients, they get transplantation, and then they can develop antibodies to the BSEP protein in the transplanted liver, and they start having the disease itself, again, itching and cholestasis. They need to have more immune suppressives or change of their immune suppressives, or they can also need a retransplant again. Regarding PFIC1, some of the patients develop steatosis in the liver, and this is not exactly known why they do that. And they might also develop diarrhea post-transplant, and as Dr. Iman showed that some patients now, they had ileal diversion during the transplant to avoid this, steatosis and diarrhea. Now, why do we have to preserve the liver? Preservation of the liver in metabolic liver disease, as we can, we preserve their native liver, especially if they don't have a liver disease. Why? Because it might be the target organ for gene therapy. Maybe in the future we will have an enzymatic replacement. Maybe we'll have a gene therapy to tackle these problems. So if we have their native liver, it will be better. By preserving their native liver is by what? By doing auxiliary transplant or hepatocyte transplant. This is auxiliary transplant, so you keep the liver, their native liver, you just add a graft beside it and you connect it. And we use this for patients who have no hepatic disorders like Crigler-Najjar syndrome. King's College, they published their experience with auxiliary transplants in metabolic liver disease, and they found that they have good patient and survival rate compared to the other non-metabolic. other types of transplantation. Hepatocyte transplant, urea cycle defects represent the most common metabolic liver disease treated with hepatocyte transplantation. We need around 5 to 10% of liver to produce a good enzyme or to produce a good function. So we only need around 10% of a liver mass. So if we could achieve that with hepatocyte transplant, it will be good. Safety of the method was confirmed, but the efficacy of hepatocyte transplant was not maintained over a long time. Then comes a domino transplantation. What is domino transplantation? We have to mention this when we mention metabolic liver disease. This is the extracted liver of a patient, of a metabolic liver disease patient who has no liver disease. We take his liver, after transplanting him, take his liver and transplant it in another patient who is on the transplant list who has cirrhosis or hepatocellular carcinoma. Okay. It's a good option for patients on the waiting list, and MSUD patients, these are the usually used livers. Now, for this 1 minute, I will tell you about our experience in Kuwait. We had the indications of our transplanted patients. Around 41% of the indication of our transplanted kids are for metabolic liver disease. Extrahepatic biliary atresia, which is considered to be the major cause of liver transplantation in most of the centers, it's only 24% in our patients. The non-metabolic liver disease, 47%, the metabolic liver disease is 41%, and PFIC 12%. If we combine now, PFIC is combined within the metabolic liver disease. So we get this figure, around 53% of the indications in pediatric liver transplantation in Kuwait is due to metabolic liver disease. I found 2 articles in Saudi Arabia. They have the same thing. Okay, they have the metabolic liver and genetic are the most indication. Most of our metabolic liver disease is biliary atresia. Remember, in the States, it was urea cycle. In Japan and Korea was Wilson's disease. Here in my country, it's Krieger-Najjar syndrome. Age, around 5 years, the median. Year of transplantation, as we go, all the years after 2011, most of the patients, many patients with metabolic liver disease were transplanted up because, you know, they hear from each other, the patients hear from each other, and also the metabolic specialists started to send these patients for liver transplantation. Presentation, we have mainly extrahepatic manifestations. So the first figure on the left side, this is including PFIC, and the one on the right excluding PFIC. So if we exclude PFIC, 73% of these patients presented with extrahepatic, so they don't have a liver disease, their liver is normal. And mainly, chronic liver disease is the main presentation. The type of transplant, liver transplantation, orthotopic liver transplantation is the...
I think you have to conclude.
Okay. Type of graft, cadaveric. Oops. And the rest, I think,
not from our side.
It's okay. Thank you.
Okay. Thank you, Dr. Wafa, for your updated and overview of liver transplant in metabolic liver disease.